The following podcast is part of a certified educational activity titled Prevention at Every Age, a team-based approach to meningococcal disease vaccination for at-risk populations. Access the entire activity and complete the post-test at peerview.com/QBC860. Downloadable slides and practice aids are also available.
I'm Dr. Gary Marshall. I'm a professor of pediatrics and chief of the Division of Pediatric Infectious Diseases at Norton Children's and the University of Louisville School of Medicine in Kentucky. This program is called Prevention at Every Age, a team-based approach to meningococcal vaccination for at-risk populations. During this presentation, we hope that you'll learn that identifying high-risk groups helps reduce invasive meningococcal disease, or IMD, burden in disproportionately affected populations. We also hope that you'll learn culturally responsive shared decision-making supports vaccine confidence and equitable access, and that appropriate vaccine selection and administration depend on current evidence and new mechanisms of action. Finally, team-based strategies can address disparities and improve vaccination uptake. So there are a few things that you need to know about IMD. The first is, this is a disease caused by Neisseria meningitidis, which is a gram-negative diplococcus, pictured here in a spinal fluid gram stain. IMD can be very serious. You see here an example of a patient with puerperal fulminans who also has sepsis and meningitis, and this is a typical presentation for this infection. IMD can also be deadly. This is a study that looked at case fatality rate by age. Each circle represents a different study, and the size of the circle is proportionate to the size of the study. And you'll notice that there are 3 inflection points on the graph. One is in infancy, the next one is in adolescence and young adulthood, and the third one is in the elderly. Those are the 3 peaks in incidence, which we'll get to in a minute. But also note that the case fatality rates differ by age, such that for the elderly, the case fatality rate is very high, and it's next highest for adolescents and young adults, and it's the lowest for infants. But even there, for infants, the case fatality rate is 10%. And by the way, that has not changed, even though we have wonderful antibiotics to which the bacterium is exquisitely susceptible. And it's also not changed with all of the new interventions we have to control the inflammation that is caused by the infection and by meningitis. Another thing to know is that IMD can present in 2 main ways. One is meningitis, that's about 50% of cases, and the other is septicemia, which is about 30% of cases. As you can imagine, meningitis presents with headache, stiff neck, nausea, photophobia, and altered mental status, and septicemia can present in nonspecific ways with chills, cold extremities, myalgia and arthralgia, vomiting and diarrhea, petechiae or purpura, and then hypotension and the rapid onset of shock. Also know that there's overlap between these 2 clinical syndromes, so that many patients with meningitis also have septicemia. Here's one of the scary things about meningococcal infection. Early on, it is difficult to distinguish between IMD and relatively benign viral infections. So here are 2 patients, both not feeling well, and both have a rash. The one on the left has meningococcemia. And if that person doesn't get antibiotics, they can get very sick very quickly. Whereas the person on the right has enteroviral infection, which, as you know, is pretty benign. And so because this disease is difficult to recognize early on and can progress very rapidly, vaccination is the best strategy we have for preventing the serious outcomes. It's also important to know that survivors of IMD can have lifelong sequelae. This is a child who lost her limbs, and there are many other sequelae, including neurologic, psychological, other physical sequelae. And then there's a substantial economic burden and a social burden in terms of the families and the caretakers of the survivors. Neisseria meningitidis colonization precedes IMD. What happens is that a person comes in contact with the organism, which then adheres to the respiratory epithelium, and it hangs out there until it can gain access to systemic circulation. And a large percentage of people are colonized. This is a study that looks at colonization rates on the y-axis and age on the x-axis. And again, the circles are proportionate to the size of the studies. And what you'll notice here is that colonization rates range anywhere from 5% to maybe 25%, but they peak among adolescents and young adults. And there, it can be as high as 25%. And the reason this happens is because this age group hangs out together in close quarters. They may be in residential colleges and dormitories, for example. They frequent bars and social clubs, and they have frequent exchange of secretions. And this is how the organism can spread. But it's not just being colonized that's the issue. We don't understand why some people get IMD and others just go on being colonized. We know, though, that one of the factors can be disruption of the nasopharyngeal epithelial barrier. That can occur because of smoking, for example, or it can also occur because of concomitant infections. So there's a well-known correlation between influenza epidemics and increases in meningococcal disease. And that's probably because influenza can infect people who are already colonized with meningococcal bacteria, and then those bacteria can gain access to the systemic circulation. Well, here's another thing to know. IMD is incredibly rare. So even before we had vaccination programs for adolescents in the United States, the incidence was very low, 1.2 per 100,000. The incidence went down over a period of decades for really unknown reasons. By the time that the meningococcal ACWI program was instituted in 2005, the incidence was around 0.4 per 100,000. It declined further after that, probably for the same reason it had been declining all along, but in addition, there was an effect of the vaccine program. MenB was introduced in 2015, and since then the rates have drifted down to the point where now they are 0.13 per 100,000. That's about 1 in a million. Just to give you some perspective on this table shows you the incidence of various vaccine-preventable diseases in the year that those vaccine programs were started. So, for example, measles occurred at about 2,100 cases per 100,000 population in 1963 when the measles vaccination program started. So you can see here the difference, right? Orders of magnitude lower incidence rates for this disease, for which we also have vaccines. So let's discuss the epidemiology a little bit. We talked about the 3 age peaks for incidence of IMD. The first one in infants is fairly easy to understand because young infants are protected by maternal antibody, but that antibody wears off. And these are infants that then get exposed to older people, such as teenagers in their environment, who may be colonized with the organism. We talked about the behavior and environmental factors that affect the risk in adolescents and young adults. And then for the elderly, it appears to be immune senescence that predisposes them to IMD. Another really important point is that the epidemiology of IMD is unpredictable. So we talked about declining incidence over time, but what was a surprise beginning in 2022 and ongoing till now was the increase in incidence in serogroup Y disease. Turns out that this is probably mostly a virulent clone that was introduced into the United States around that time. And it's spread in several different circumspect populations. But the point is that when the serogroup distribution is so different from one country to another, we don't know when a particular serogroup or a particular clone is going to be introduced into the US. There are other risk factors besides how old you are. So I divide those into the biological risk factors and the epidemiological risk factors. So, for example, people who are asplenic or have complement component deficiency are at increased risk for IMD because they don't have complete immune defenses against the organism. Likewise, people who are working in a laboratory or living in crowded conditions or traveling to an endemic area are also at risk for reasons of exposure. And then there are certain risk factors that I think cross between the biology and the epidemiology. So, for example, we've mentioned bars and clubs, which represent a risk because of close contact and exposure, but at the same time, there is drinking and smoking, and that can also increase the risk. HIV infection is another example where you may be at increased risk because you are immunocompromised, but in addition, you may be exposed to other people in your community who are colonized and can spread the organism to you. So let's focus down a little bit on the adolescent population. You'll notice that the blue column is the largest, and the blue represents serogroup B. So in fact, serogroup B is the most common of the serogroups to cause invasive disease in this age group. Also know that it's the most common, in fact, it's the exclusive cause of college outbreaks. This was a study that looked at college outbreaks from 2011 to 2019. Again, the size of the circle is proportionate to the size of the school, and the number of cases is shown in the center of the circles. So all of these outbreaks that occurred on college campuses were serogroup B. So just to graphically summarize the bottom line, we have a disease that is extremely severe and has a high case fatality rate that can result in severe sequelae among survivors. It's difficult to recognize early on, and we don't know when we're being exposed. And that leads to unpredictability in terms of the local epidemiology, but also unpredictability in terms of serogroups that may become prominent in the future. All the while, we do have, represented on the right-hand panel, a full-fledged vaccination program. And in the middle panel, the representation that we are living in an environment where the absolute incidence of disease is very low. Here's another way to summarize the bottom line points. IMD can be fatal or can cause severe long-term effects in those who survive. And this makes early recognition crucial, but honestly, it's what makes vaccine prevention crucial. IMD risk factors include age, so it's higher risk in adolescents and young adults, living conditions, so it's a higher risk in college dormitories and military barracks, and then individuals with conditions like asplenia, HIV infection, or complement component deficiency. And there are also specific age groups that are high risk, and we've discussed those age groups. Close contact and mucosal irritation facilitate colonization and infection, especially in young people, and vaccination is the key to protecting those who are at risk of IMD. Before we talk about the vaccines, we have to talk about the bug. So this is a cartoon that represents the meningococcus. You can see a few of the important structures. One is the light blue outer portion, which is the polysaccharide capsule. This has a lot to do with the organism's ability to evade host immune responses. But fortunately, at least for serogroups A, C, W, and Y, the capsular polysaccharide is immunogenic. So just like was done for Hib and was done for pneumococcus, The meningococcal polysaccharides were hooked up to protein carriers and became very effective conjugate vaccines. That strategy, however, did not work for Men B, and that's because that meningococcal B polysaccharide is not immunogenic in humans. And so we had to fall back on the proteins that are embedded in the outer membrane, shown here, to be the vaccine antigens that we could use. And so there are a number of these different proteins that are exposed on the surface of the bacterium to which antibodies are neutralizing. And that is what the Men-B vaccines are made from. There are 6 vaccines that are available in the United States. 2 of them, shown here in the blue, are ACWY conjugate vaccines. 2 of them in the green are Men-B outer membrane protein vaccines. And then the 2 in the purple on the right are 5-valent vaccines. So these are vaccines that have combined serogroups A, B, C, W, and Y in the same syringe. So this slide also shows you the age indications for these vaccines, the manufacturers, and the usual dosing schedule. Let's now look at the routine immunization recommendations. So on this graphic, the yellow indicates where doses of Men-ACWY are routinely indicated. The first dose is at age 11 to 12, and the second dose is at age 16. The blue shows where Men-B is recommended under the shared clinical decision-making paradigm, which we will talk about, and the preferred age there is 16 to 18. If you are giving both ACWY and B on the same day, then it's recommended to consider using the pentavalent vaccine or the ABCWY vaccine. The purple shows the range of ages where special recommendations exist for high-risk individuals. And so you can see here that if you know that a child is born asplenic, that would be considered high risk, and they can be vaccinated with the ACWY conjugate as early as 2 months of age. The Men-B vaccines are not licensed before age 10, but if you knew that you had someone who fell into one of those high-risk categories, then you could initiate the vaccine series at 10 rather than waiting until they are 16. This slide summarizes differences between the recommendations for ACWY and those for B. So both are recommended for healthy adolescents, the ACWY routinely, and the Men-B under shared decision-making. They're both recommended for functional or anatomic asplenia, persistent complement component deficiency, exposure to the organism, for example, microbiologists, and then in outbreak situations. And usually those outbreaks are declared by health departments and the vaccine recommendations are issued at that time. Also know that ACWI is recommended for travelers to endemic areas, college freshmen living in dorms, military recruits, and persons with HIV, whereas Men-B, for example, is not recommended as a travel vaccine. And then for those special populations like asplenia or complement deficiency, the earliest ages for vaccination are listed here on this table. Know as well that the primary series for these vaccines is a multi-dose series. Just to highlight what I mean by that is a healthy adolescent would get 1 dose of ACWI at age 11 to 12, then a second dose at age 16. But a high-risk adolescent would get 2 doses of ACWI as the primary series at age 11 to 12, and then would get the booster at 16. There are also recommendations for high-risk individuals to be revaccinated periodically, every 5 years in general for ACWI and every 2 to 3 years for Men-B. I'm not going to belabor data on effectiveness, but this is a summary slide from the ACIP that makes the point that ACWY is very effective, over 90%, against those serogroups. And Men-B is also very effective if you get the 2-dose series. And this is a problem because, as you'll see a little later, many of the people who initiate the Men-B series, which isn't a whole lot to begin with, do not get the second dose and therefore are not fully protected. Also, it stands to reason that for the pentavalent vaccine, because you have both ACWI and B in it, we're going to see 90-some% effectiveness for the ACWI component and effectiveness that parallels the effectiveness of monovalent Men-B vaccine. Well, I keep talking about this shared clinical decision-making. What is that? Well, you know what it is because you engage in that every single day with every single patient. It's not something novel and it's not something new. So it has a lot to do with, though, what ACIP recommendations look like. So in general, ACIP will recommend a vaccine routinely, or they'll recommend catch-up or risk-based vaccination, which basically means everyone in this age group or this risk category should get the vaccine. The language that's used is recommend or should. So ACWI is routinely recommended at 11 to 12. Sometimes ACIP will issue a recommend against type of recommendation. An example of that was the decision to not recommend ACWI between ages 2 and 10. And the reason for that is the incidence of disease is even lower than the general population incidence in that age group. And then there is a special type of recommendation, which is a recommendation, but it relies on shared clinical decision-making. And that means that there must be guidance in the context of individual patient interactions. And the language that's used for SCDM recommendations is may. What's the difference between a routine recommendation and SCDM? Well, it's a difference in the default position. So the default for a routine recommendation is to vaccinate. The default for SCDM, well, there is no default. You either can vaccinate or you cannot vaccinate. It depends on the outcome of that interaction with the patient. The good thing about SCDM is, as a recommendation, it is covered by insurance under the Affordable Care Act, and it is covered by VFC. And that's really an important thing about SCDM. A lot of people ask, well, why is Men-B recommended under SCDM rather than routine? When you've already told us that serogroup B is the most common serogroup in teenagers. It has a lot to do what we didn't quite know in 2015 when the recommendation was first made. So we already knew the incidence was low, but we didn't know how long immunity would last. We didn't know if there was an effect on carriage or whether there'd be herd effects like there are for ACWY. As it turns out, we now know many of these things. For example, vaccine immunity does wane fairly rapidly, and that's why we do those every 2 to 3 year boosters for high-risk people. There don't appear to be herd effects, and that's because we don't have an effect on nasopharyngeal carriage like we do with ACWY. And there's also a very high cost per quality gained. And so for the time being, Men-B remains an SCDM recommendation. One of the things about SCDM is that a lot of the outcome of the discussion depends on how you frame the problem. So, for example, when we're talking about Men-B vaccination for a 16-year-old, we could frame the situation in terms of loss. We can say, listen, if you take this vaccine, then your chances of getting serogroup B meningococcal disease in the next 4 years will be reduced by 79%. That sounds like a no-brainer. But by the same token, we could frame this as a gain by saying that if you take this vaccine, you will be serogroup B disease-free over the next 4 years. And you will be 1.000005 fold more likely to be disease-free for those 4 years than if you didn't take the vaccine. So do you see the difference there? These two things are mathematically equivalent, but a lot of the outcome of that discussion will have to do with how this is framed for the patient. Another thing that needs to be taken into account is the individual's characteristics, their values, their preferences. Well, what are their values and preferences? I offer here a discrete choice experiment that was done to try to get at that question or get the answer to that question. And the outcome of this study was that parents, shown here on the left, and patients or teenagers, shown on the right, both tend to view a disease like meninge, which is 1 in a million, but you can die from it, as pretty much similar to a disease like flu, which is much more common, say 1 in several thousand, but that generally won't kill you if you're a healthy teenager, but it could put you in the hospital. So the point is that this is a hard equivalency to get at, and it's certainly one that's difficult to take into account when we're trying to capture all of the benefits of a vaccine program. In this case, I would say that it's a peace of mind value that is difficult to capture in cost effectiveness models. Speaking of cost effectiveness, just so you know, there are some models that look at, well, how much does it cost us to prevent IMD or to prevent a quality adjusted life year that would have been lost if it weren't for the vaccine program? And you can see here that for the base program for ACWI, the 2 doses, assuming herd protection is operative, then the cost is around $200,000 per quality gained. Whereas for the 2-dose men ACWI and then the Penta plus B at age 16, the cost is somewhere around $750,000 per quality gained. Just to put that into perspective, when the HPV vaccination program for girls was started many years ago, it was estimated that the cost per quality gained was about $3,000. So you can see why it's been difficult to put meningococcal into the same perspective as many of our other vaccines that we have. The ACIP signaled back in 2024 that it may be relooking at meningococcal vaccination and possibly changing the program. They want to look deeply at risk factors, assess the changing epidemiology, and include the duration of vaccine immunity to optimize protection. These were some of the proposed options that might be seriously considered. You can see in the top line under current is what we're doing now. That's what we've been talking about. But going forward, there's a possibility that they may feel that the 11 to 12 dose is not necessary or it should be pushed back to age 15. And for men B, it may stay as status quo, or it's possible that it could become strictly a risk-based type of recommendation. And then what is the role for the pentavalent vaccine now that we finally have that? How do we fit that into our meningococcal program? So these are all questions that hopefully we'll have the answer to in the next few years. So the bottom line is we have 3 different types of vaccines: the conjugate vaccines for ACWI, the protein vaccines for B, and then the combined pentavalent vaccine. The ACWI is routinely recommended for adolescents. Men B is recommended for adolescents under shared clinical decision making. Both ACWY and B are recommended routinely for people who are at increased risk for meningococcal disease. And ABCWY or pentavalent may be used in situations where you're giving both ACWY and B on the same day. So this is a graphic sort of pathway that walks you through our understanding of what parents know and understand about meningococcal disease and vaccination, and what healthcare providers know. And I won't go through all the details, but I'll tell you that on both sides of this winding path, there has been a lot of confusion and really some very substantial knowledge gaps, such that many parents and patients do not know about IMD. They don't understand the differences between the vaccines, which ones are routine and which ones are shared decision making. And likewise, many providers are confused about this. And that's true even today in the 2020s. Just to give you an example of some of the data we have, this was a study looking at physician knowledge, attitudes, and practices related to MenB and ACWY. And it was a survey of some 407 physicians, family practitioners, internists, pediatricians. And you can see here that when you look at all physicians, only 46% of them, shown here in the red box on the first column, understood that MenB is recommended under the shared clinical decision-making paradigm. And so that means that in some cases, a majority of them did not know that or felt that this was a routine recommendation. And then similarly, for the ACWI booster at age 16, in some cases, as few as 65% of physicians were able to identify the recommendation as a routine recommendation, not an optional recommendation. And then the data were very similar when we asked nurse practitioners and physician assistants the same questions. So many of them not recognizing that MenB is shared decision making. That's the opposite of the red box here. And then for ACWY, not 100% knew that ACWY was a routine recommendation for age 16. One of the problems with SCDM is that it could potentially lead to some disparities. So these are data showing that initiation of the ACWI series at age 11 to 12 is pretty good for both privately insured and for Medicaid insured kids. However, if you look at MenB initiation, remember that's the one that's SCDM, you can see differences from the index point going forward in terms of the proportion of commercially insured versus Medicaid insured kids that are that are covered. And so that suggests that SCDM may not be occurring equitably between these two populations. Or it could be that the SCDM is occurring and Medicaid insured patients are simply opting out. The reason this is a problem, this is why I worry about this, is when you look at MenB disease across 18 to 24-year-olds, most of it is in college students, but about a third of it is in kids who are not going to college. And so if we just focus our SCDM efforts on those kids who are headed for college, we're going to be missing a substantial proportion of the population that is still at risk for MenB disease. So the bottom line is that ACWI is routinely recommended for all adolescents, 2 doses. MenB is recommended under the shared clinical decision-making paradigm, and that's at age 16. And ABCWY, or the pentavalent vaccine, is recommended in the circumspect situation where you are planning to give both ACWI and B on the same day. We do have barriers to uptake, particularly in high-risk groups. And a key strategy is that shared decision-making and education to increase vaccine confidence and access. How well are we doing on coverage for these vaccines among adolescents? Well, these are data from the National Immunization Survey team that look at 13 to 17-year-olds. And in 2024, you can see the good news is that in the black column row at the top, Tdap uptake is very good, over 90%. And even the HPV series is gaining ground and is now over 60%. And for meninge, the good news is that nearly 90% or slightly above 90% are initiating the ACWI series. However, 32% of those who get that first dose are not getting the second dose, which is recommended at age 16. And then it might not surprise you that for initiation of Men-B, we're at around 37%. And I say not surprisingly because, remember, that's an SCDM recommendation, not a routine recommendation. But the disturbing news is that 57% of those who initiate do not complete. And if you remember from a previous module, if you don't get all the doses you're supposed to receive, you're not protected. And so we really do need to focus on at least completing the Men-B series, if not also getting more kids and their parents on board to understand the risks, understand that they're in a risk group based on their age, and to have that fully fleshed out discussion about Men-B disease and vaccination. Here are the data showing that for the high-risk people, asplenics, for example, in this graph, HIV infection in this graph, and complement deficiency in this graph, you'll see that from the index date, which would be the date you were diagnosed with a complement deficiency, and therefore would fall under the routine recommendation for both vaccines, you can see here that the uptake really is very low, less than 10%, even 5 years out from being diagnosed with that high-risk condition. So what can we do to better communicate about this with our adolescents? The first piece of advice I would have is to go to the website of the American Society for Meningitis Prevention. These two girls both lost their lives to invasive meningococcal disease. They were high school seniors or college freshmen who abruptly became ill and died. And their mothers founded ultimately what became the ASMP. And they are really dedicated to making sure that all teens know about this disease and are appropriately counseled and vaccinated. And so they have some wonderful trifold brochures that you can get, that you can hand out to your families. These have roadmaps in them for how do I become protected? When are my vaccines due? And they have brochures that are appropriate for students as well as those for health professionals. One of the useful things, very useful things here is a reminder card that says, you got your first dose on this date and it was this vaccine. Here's when you should come back for your next dose. So how do we have confident meningococcal vaccine discussions? This is sort of a 5-step pathway. The first is to lead with why. Why are we doing this? It's because it's a very serious disease that, yes, is rare, but that can progress extremely rapidly, too fast sometimes for antibiotics to even make a difference. And we want to emphasize that the disease is unpredictable and that vaccination is really the best way to prevent it. We want to make sure our parents understand that we have the 3 different types of vaccines. And that's really important because many of them may feel like after they get the quote meningitis shot at 11 years of age, they're protected against meningitis. Well, they are if it's ACW or Y, but they are not protected against B. So they need to know that. And then when they turn 16, they need to know that there is a MenB vaccine and it is an option if they want. I think it's really helpful to make this discussion personal. I always tell parents and kids, teenagers about my own kids. I tell them that they were vaccinated with all the doses of vaccines when they were scheduled to be given. And I also tell them about cases I've had of kids with IMD and what the tragedy of that disease is like. Now, you may not have had a case in your own practice, but surely when you were in training and possibly since then, you have come across cases or know about cases that have occurred. We need to recommend vaccination with confidence. So we need to take that presumptive approach. So good news today, we've talked about all the routine health issues that we talk about for 16 years of age, sex, drugs, rock and roll. And now you're also going to get your second dose of the meningitis shot for ACWY. And I think it's a good idea to get your first dose of MenB, but we can discuss that further. That's the presumptive approach, not you're due for some shots today. What would you like to do about that? And then there are various resources that can help us in having these discussions. And it's also important to be consistent across your care team so that, for example, when you know, a receptionist at the front desk can actually have an effect, either a positive one or a negative one, when it comes to vaccinating your patients. So I would make sure that your receptionists, your medical assistants, RNs, PAs, NPs, other doctors, everyone in the practice is on board. And this is a summary slide of some talking points for MenB in particular for adolescents. We've gone through all of these in the context of these 4 modules. This will be available to you offline as durable materials that you can refer to it and print it out maybe if you feel that would be useful. We did some work on college campuses where we asked college students or college or healthcare providers that take care of college students or even campus leaders, tell us what the barriers are. Tell us why college students may not want to be vaccinated. And interestingly, potential for side effects was a big one. Many of them just weren't convinced or didn't know about their own personal risk for IMD. And believe it or not, many of them were afraid of injections. But there's also uncertainty about which vaccines am I supposed to get? Which ones have I already received? I seem to remember getting some shots when I was 16, but that was 2 years ago, so I don't remember what that was. Or maybe I'm too busy to get vaccinated, or maybe the vaccine is not stocked in the infirmary and it means me having to either go home or to go off campus, to a pharmacy or something like that. So there are lots of barriers, but the good news is that when we did these studies and we went in with a little, 1 hour long seminar for students about this disease and the vaccines, many of them, most of them, in fact, went out and got vaccinated after that educational program. So we need to remember to talk to our parents and to our patients about meningococcal disease, about the different vaccines, and about the risk that they have for the disease. And we need to pay attention to the recommendations that come out of the ACIP. But we also need to pay attention to the recommendations that come out of the Academy of Pediatrics and the American Academy of Family Physicians, because these are also important sources of guidance. So the bottom line is that there are barriers to vaccination that include knowledge gaps, suboptimal uptake among high-risk populations, like those with HIV or with asplenia, logistical challenges, vaccine hesitancy, and lack of vaccine confidence. Shared decision-making is the key for improving vaccine uptake, especially for Men B. And communications with patients and or families should be clear, confident, presumptive. Having educational materials available for them to take home with them are essential to address the concerns they may have and to improve their confidence. And then especially focusing on overcoming those barriers in college students, but in non-college students as well, or non-college attending people as well, to ensure that we complete the vaccine series that we've initiated.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Train Learning Network. This educational activity is supported by an independent medical education grant from GSK. To access all materials for this activity, visit peerview.com/QBC860.